Hello class, this is Lisa Peden and I am going to record the second part of the Neurological Emergencies lecture. We're going to start off talking about increased intracranial pressure because this will affect many of the disease processes that I will speak of later. First, intracranial pressure is the pressure that is exerted by the combined volume of the three components of the cranial vault. Now, I want you to think about the cranial vault as a rigid box that does not expand in the adult. So the skull is a rigid box and it contains three components: brain tissue, blood, and spinal fluid. Now, the Monroe-Keeley hypothesis says that because of the limited space for expansion within the skull, rigid box, an increase in any one of these three components causes a change in the others. So things like bleeding, edema, overdilated blood vessels, tumors are going to occupy space and affect the balance of these three components within the skull. A normal intracranial pressure is 10 to 15 millimeters of mercury. And I need you to commit that to memory just like you would your normal vital signs. A normal ICP is 10 to 15 millimeters of mercury. And again, you will see this number increase with several different things, namely brain injuries, stroke, and cerebral edema. When this intracranial pressure increases, it causes a decrease in cerebral perfusion. So the cerebral cells and tissue are not being perfused adequately, and that results in tissue hypoxia. Tissue hypoxia then causes brain swelling or cerebral edema. The next step is that with the cerebral edema, the serum pH of the body changes. It decreases. This causes an increased carbon dioxide level, which causes cerebral vasodilation. Vasodilation then causes more cerebral edema, and the cycle repeats itself. So all the measures that we will use to decrease intracranial pressure are aimed at decreasing cerebral edema. Cerebral perfusion pressure is another definition and normal that I need you to memorize. Cerebral perfusion pressure is the pressure that is needed within the cranial vault to drive oxygen into the cerebral tissues. It is calculated by obtaining a mean arterial pressure, which is an average of the patient's blood pressure, and subtracting their intracranial pressure. This gives us a normal cerebral perfusion pressure of 70 to 100 millimeters of mercury. Now, many of the Dynamaps will calculate a map for you, but there is a formula that we calculate the mean arterial pressure, and it is the systolic blood pressure plus the diastolic blood pressure times 2 divided by 3, and this will give you a mean arterial pressure. If the mean arterial pressure is low and the intracranial pressure is high, the patient may have an inadequate cerebral perfusion pressure. The body responds and tries to compensate and you will see that the patient has bradycardia, a widening pulse pressure, which is the difference between your systolic and diastolic pressure, and their respiratory rate becomes slower as a means of compensating. If we don't bring the increased intracranial pressure down and increase the cerebral perfusion pressure, we risk a patient herniating their brain into the foramen magnum, and this will result in brain death. Your book has a small paragraph about brain death and some criteria there for establishing brain death. But please know that the hospital or institution in which you work will have very specific policies about establishing and pronouncing brain death, and who may do that. So this is going to be individualized as far as each hospital's criteria for determining brain death. Now, I realize that content that I just said was very complex, so I'm going to provide you with an example here. If we have a patient who has an elevated intracranial pressure of 20 millimeters of mercury, I want to show you how that affects their cerebral perfusion pressure based on what their blood pressure is. So if this patient has an ICP of 20 and his blood pressure is 140/80, I'm going to calculate a mean arterial pressure of 103. I'm then going to subtract the ICP from the MAP and obtain a cerebral perfusion pressure. In the first case on the left, we get a 83 cerebral perfusion pressure, and we know that this is adequate. If this same same patient's blood pressure drops to 100/60, their mean arterial pressure drops to 73. And when we subtract the ICP from 73, we can see that the patient has an inadequate cerebral perfusion pressure. So this example explains why we always like our neuro patients who have a risk for increased ICP to have a permissively higher blood pressure. It maintains their CPP within an adequate level. When I say permissive, I mean that we recognize the blood pressure is slightly elevated, but we give the patient permission for this higher blood pressure because we know that the cerebral vessels are trying to compensate for the increased ICP. Once we have an increased ICP, we're going to first assess it and monitor it, and then we're going to take some very specific actions. In order to obtain an ICP, the patient must have an ICP monitor, and this patient must always be in ICU. There are 4 types of ICP monitors, and you can see by the names where they are located in the brain. I'm not going to go into a lot of detail about these because your book doesn't, but the first one, the ventriculostomy, is a catheter that sits in the ventricles and is the only monitoring device where you can drain CSF. Okay, we're going to try and decrease the patient's cerebral edema. The first drug of choice is going to be an osmotic diuretic called mannitol. Mannitol pulls water out of the extracellular spaces of the brain tissue. You would expect to see an increased urine output after mannitol. It is given in boluses rather than as a continuous infusion. You may IV push mannitol, or you may hang it in a mini bag to infuse over a short period of time. Also, please know that mannitol is a salt and it will crystallize inside the IV fluid bag. So when you are either drawing this mannitol up into a syringe to push, or you're hanging it to infuse over a short period, you must use a filter needle and you must have filters in the IV tubing so that these crystals are filtered out. The second drug we might give to decrease cerebral edema is a corticosteroid called dexamethasone or Decadron. We all know how steroids act. Those are going to decrease the inflammation and hopefully provide more space within that cranial vault. Now, these are patients that you don't want to fluid overload. We don't want those vessels distended even more than they already are. So they may be put on some type of mild fluid restriction. They will still be getting IV fluids, but this is not a patient that you want fluid overloaded because there's just not enough space in the cranial vault to accommodate overloaded blood vessels. So our goal is to maintain an adequate cardiac output and blood pressure and an adequate cerebral perfusion pressure to maintain all of these while we're intervening. Some other management techniques are cerebrospinal fluid drainage. And it's exactly like it sounds. You open up the ventriculostomy and drain enough spinal fluid to decrease the ICP. But remember, the only way you can do that is with a ventriculostomy monitoring and drainage device. We want to use cautious hyperventilation in these patients. We want them to be have a PaCO2 of 30 to 35. So we want to decrease their serum CO2 just a little. Carbon dioxide is a very potent vasodilator. So if we can blow off more CO2, it may lead to just enough vasoconstriction within the vessels to provide room in the cranial vault. Now, your book talks about hyperventilation as being very controversial, but I did go ahead and add this because you can use this mechanism if you get into a situation where the patient's ICP is climbing. Now, in order to do this, you would need to have your patient on a ventilator. You would turn up the rate on the ventilator, or you would connect them to an ambu bag and bag them just to help them blow off enough CO2. Temperature control in these patients is also very important. Because of the area of the brain that may be affected, they may have an increased temperature or a decreased temperature. We want to keep them as close to a normal body temperature as possible. If they become feverish or antipyretic, we want to use Tylenol and maybe a cooling blanket to bring that down. But we don't want them to shiver. Sometimes if we bring temperatures down too fast and too low, it causes shivering in our patients. But shivering increases the metabolic demands of the brain and also increases ICP. So we want to control their temperature without making them shiver. The last two measures to decrease ICP involve putting the patient into a medically induced coma. If we put them into a barbiturate coma, this again is going to decrease the metabolic demands of their brain so that during the time of cerebral edema we can prevent any further damage. Some of the drugs we would use would be Presidex, pentobarbital, or propofol. Along with that, we may use pharmacological paralysis. This is another way of reducing the metabolic demands of the brain. The patient is given paralyzing agents, IV, so they cannot move. But remember, during both of these treatments, they must be on a mechanical ventilator and also given analgesics for pain because they will still feel sensation. So traumatic brain injury is a time when we often see an increased intracranial pressure. A traumatic brain injury is simply defined as a mechanical force is applied directly or indirectly to the brain. Some of the causes are motor vehicle accidents, falls, especially in the elderly, assaults such as the use of firearms, and sports injuries, which account for about 10% now. Young males are the most affected, and commonly alcohol and drugs are also involved in some of these brain injuries. Also consider that the elderly population has the second highest incidence of TBIs, and these are usually due to falls. These are the types of primary brain injuries. An open brain injury means that there has been a break in the skull due to the skull striking a surface or an object striking the skull. And in this case, they would have a skull fracture. A closed brain injury means that there has been some kind of uncontrolled energy transmitted to the underlying brain tissue, causing damage. But the integrity of the skull is not violated, so closed head injuries do not have a skull fracture. With the open head injuries, the brain and the dura are exposed to contaminants in the environment. There are different types of skull fractures, and you see them listed here. I want to call your attention to the basilar skull fracture. This is a fracture at the base of the skull, which tends to cause spinal fluid leakage, either from the nose or from the ear. The patient with a basilar skull fracture will sometimes commonly have this battle sign. This is an area of bruising over the mastoid area behind the ear. They also may have CSF otorrhea, which is spinal fluid leaking from the nose. Otorrhea is spinal fluid leaking from the ear, and rhinorrhea, which is spinal fluid from the nose. You may see halo sign, which is a small area of blood that is then surrounded by a yellow ring, either on their linen, on their clothing, on their gown, etc. These are some other closed head injuries. These are caused by blunt trauma. A concussion is sometimes referred to as a jarring of the brain. The patient may see stars, they may complain of dizziness, they may have a short period of unconsciousness. They may be admitted to the hospital overnight, or they may not be. If they're sent home with family members after a concussion, we need to be sure and teach the patient's family to report any difficulty in awakening the patient, any difficulty in speaking by the patient, or if they become confused, have a persistent headache, start to vomit, or have hemiparesis. A contusion is a more severe injury. The brain is actually bruised. The blood pressure and pulse may decrease gradually and then return to normal, and the patient may have a residual headache and dizziness, but generally their period of unconsciousness is longer than a concussion, and of course we would want to be watching for those same signs of deterioration. A diffuse axonal injury is a very widespread brain injury that is then further divided into degrees. The patient will have really no clear or lucid intervals. Immediately after the injury, they are unconscious. They may have some of the abnormal posturing that we talked about in assessment, and they are developing cerebral edema. And for these diffuse injuries, the prognosis will really depend on the degree of injury and how their brain recovers. This is another way of classifying brain injuries, and there's a chart in your book. A mild brain injury includes a brief loss of consciousness up to 30 minutes. They may have retrograde and antegrade amnesia surrounding the event, and they may be somewhat confused, but they recover very rapidly. A moderate traumatic brain injury means they have a loss of consciousness from 30 minutes to 6 hours, and their symptoms can be permanent. They can recover, but sometimes they have lasting deficits. A severe brain injury means that they have a prolonged level of loss of consciousness longer than 6 hours. They may have a more limited recovery, and they may have a permanent disability. And you see the Glasgow Coma scales that are associated with each level. With head injuries, the patient can have a hemorrhage in the brain, may have a hemorrhage in the brain. We also call these hematomas, and we will use those words interchangeably. These are collections of blood that develop within the cranial vault. Cerebral ischemia will result from compression by the hematomas. The symptoms really depend on how fast the blood accumulates and the areas affected. Subdural hematomas are collections of blood between the dura and the brain. This space is normally occupied only by a very thin layer of fluid. The most common causes of subdural hematomas are trauma, coagulopathies, and aneurysm ruptures. These are usually venous bleeds, and they can be acute, which is 24 to 48 hours of symptoms, subacute, which means the symptoms occur 48 hours to 2 weeks later, or chronic, which means the symptoms may not start for 2 weeks. The treatment of subdurals is a craniotomy and removal of the bleeding and the clot. The second type of bleed is an intracerebral bleed. This is bleeding into the substance of the brain, and we talked about this a bit when we talked about stroke. But it is also common with head injuries, small forceful injuries such as bullet wounds, stab wounds. But as in stroke, the hemorrhages may also result from prolonged hypertension or rupture of an aneurysm. Onset may be slow, beginning with neurodeficits like a headache. We are going to support these people, control their ICP. We're going to replace their fluids and electrolytes and control their blood pressure. As you can see from the middle picture, craniotomy is not always possible to relieve this type of hemorrhage because it is very deep in the brain and cannot be reached. The third type of hematoma or hemorrhage is epidural. This is blood that collects in the space between the skull and dura. The difference with subdural and epidural is that epidural bleeds are usually arterial and they progress very quickly. The most common cause of an epidural hematoma is a skull fracture, which ruptures the meningeal artery and results in a rapid pressure buildup in this area. The patient has a very classic presentation. They have a momentary loss of consciousness at the time of the injury, but as the brain compensates, they wake up. They have a very lucid interval where they may be talking to you, and then suddenly their level of consciousness deteriorates again. They may, what we call, blow a pupil, where they have one pupil that is dilated and unreactive. They may have paralysis of a whole side of their body, but because it is arterial, they do deteriorate very rapidly. Epidural hematomas are considered an extreme emergency. Respiratory arrest will occur rapidly after that last deterioration. The treatment for this is to decrease their ICP very quickly. Sometimes this involves burr holes where we drill just a couple of 3 holes on the side of the injury to release the blood. They would then go on to craniotomy, go on to surgery for a craniotomy. And when they come back from surgery, don't be surprised if these patients have a drain to prevent any reaccumulation of that arterial bleeding. Assessment of brain injuries includes all of the things that we've spoken about before as far as assessment. We want to know specifically about the history of their loss of consciousness and how long it lasted. We want to know if they have an associated neck injury, so they need to have x-rays of their C-spine to make sure we don't have a spinal cord or a vertebral issue. We're going to use the Glasgow Coma Scale to assess their neurostatus and a shortened cranial nerve assessment when we assess their pupillary reactions. Of course, we need vital signs and temperature, and then we need to assess their airway, breathing, and circulation and use pulse oximetry. The diagnostic tests for a brain injury are, of course, at the top of the list, and number 1, a CT scan of the head. They may go on in the non-acute period to have an MRI, SPECT, and PET scans. They're going to have the same blood tests, CBC, electrolytes, coagulations. They may need to be topped in cross-match if they've lost a lot of blood. And as I said earlier, alcohol and drugs are sometimes commonly associated with brain injury, so they will have an alcohol level and drug screen performed. If they progress and do not improve and there is a question of brain death, they may have an EEG to determine as one of the criteria for brain death. Pharmacology for brain injured patients is sort of a try and see type situation. Immediately after the injury, they do need to be put on some kind of anticonvulsant. Phenytoin and fosphenytoin will prevent seizures in the early injury period. Tegretol and Depakote may be used later. They may need an anxiolytic in the early stages and even into their recovery, because anxiety is going to increase their ICP. We might use things like IV Ativan if they become agitated. Antipsychotics may be used later. As brain injury patients recover, sometimes they become combative and hostile and have profound personality changes. And so the antipsychotics you might see would be like Seroquel or Lamictal. Beta blockers like Lopressor or Inderal may also be used for behavior management to decrease the sympathetic nervous system responses that develop later in the rehab. And they may need antidepressants, again, to manage agitation and aggression. And these would be the SSRIs or SSNIs. We also, in the early stages, are going to be watching their fluids and electrolytes very closely. We are concerned that with the brain injury that they may have had the area that's involved in the hormone release damaged, where they get diabetes insipidus or SIADH. So we are looking for large amounts of urine. So we want to do urine-specific gravities, urine osmolalities, and serum electrolytes daily. Remember, with these patients, fluid management is a fine line. We don't want them overhydrated and we don't want them underhydrated. Nutrition is a challenge if they're unable to eat or if they're unconscious. They may need a feeding tube. We need to make sure they're not getting dehydrated or losing weight. If they can eat later in their course of illness, we want to make mealtime pleasant and make sure that we're doing a good swallowing assessment, making sure that they are not showing signs of aspiration, such as coughing or choking or dribbling. They may need thickened liquids, and they may need oral supplements like Ensure, Trauma-Cal, or those supplements that come in a can or box. We're really going to have to provide them with a lot of sensory, cognitive, and behavioral therapy. They need a safe, hazard-free environment. They need sensory stimulation. We need to speak to them in short, simple explanations. We need to help them develop a sleep-wake cycle, and we want to orient them and reassure them. We can place familiar objects and pictures in their rooms. Now, we do want to avoid any kind of restraints if possible in these patients. Wrist restraints, vest restraints, etc., because these patients sometimes react very violently to being tied down. So be prepared for that and try and figure out a way to avoid restraining them while also keeping them safe. Family support is very important. As I've said, the patient's personality changes, and this is very difficult for families. They may be the sole breadwinner in the family, because we know that young men are affected most commonly with total brain injury. They don't really have a predictable outcome. Patients will ask you many times, is he going to get better? Is this going to be the way he's going to be? and the doctors and the nurses just simply don't know sometimes. Um, these caretakers become very socially isolated if they're a 24-hour, 7-day-a-week caretaker. They have all of these emotions sort of in recurring cycles. Um, we need to give them as much accurate and honest information as we can without, destroying their hope. Um, we need to know that there are many support groups and family counseling groups available, and the National Head Injury is very helpful for these patients sometimes and their families. Just a word about head injuries in children. It is the #1 health risk for children and the leading cause of death in children over than a year old, um, due to falls, motor vehicle accidents, and bicycle injuries. And I have to say this, boys are affected twice as often as girls. And maybe it's just they have more risk-taking behavior. I don't know, but the statistics tell us this. Children have a very different response to head injuries. Um, their head is larger in size compared to their body, and they have very weak neck muscles and shoulder muscles, so that they are more prone to acceleration, deceleration injuries. And this means that the patient will have a brain injury at the point of contact. But then, because of these weak muscles and large head, the brain sort of shifts due to that primary impact, and they have a secondary impact on the back of their brain. And sometimes this results in more significant injuries. We also call this a coup contra coup injury, where the patient has an injury at the site of the primary impact, and then as the brain and neck bounces around, they also have an injury on the opposite surface. The Safe Kids campaign promotes and advertises the use of helmets for skateboarding, biking, motorcycles, skiing, football. They also encourage children and teenagers to wear a seatbelt and to avoid dangerous activities like riding a bike at night without lights. We want to encourage the older crowd to avoid driving greater than the speed limit or while under the influence of alcohol or other substances. And the Safe Kids campaign also talks about shaken baby syndrome, and so this is a cause of head injury. And you can see now that with a baby, their head is large, their neck muscles are very weak, and how they would be very prone to this coup contra coup type injury. Infants whose fontanelles and sutures are still open have a little bit of space in their rigid box to expand. So you would be alert to bulging fontanelles or separated sutures. They become very irritable, have sort of a high-pitched cry. They don't eat well, and you may also note distended scalp veins, and these would be signs of increased ICP in infants. Children may have headache, nausea and vomiting, complain about blurred or double vision, and may even go on to have seizures, just like adults. We've talked about the differences in the Glasgow Coma Scale for infants and children. Diagnostic-wise, these children and babies are going to have to go to CT scan too. And we can't expect them to cooperate. They need to be sedated before they go to CT scan. if we want the image to be anything helpful. So chloral hydrate is a sedative that comes in a syrup form, and so it's commonly used. Nasal midazolam or Versed is another option for children to be sedated quickly. And then if the child or infant has an IV, we can give them pentobarbital or IV midazolam or Versed. But we can't think that we're going to send an infant or child into a CT scanner who has a head injury without some type of sedation. Okay, let's talk about brain tumors now. These are localized intracranial lesions which occupy space within the skull. So I hope you're thinking back about the Monroe-Keeley hypothesis and are thinking, if this brain tumor is occupying space, that means it is displacing other brain tissue, other blood vessels, and cerebral spinal fluid. Primary brain tumors arise from cells and structures within the brain. Secondary brain tumors are metastatic, which means they have developed from structures outside the brain. And a lot of cancer patients will go on to have secondary brain tumors due to metastasis. All right, I've already said this, but remember, all tumors are going to occupy space and cause effects from compression and infiltration. They're going to have an increased ICP probably, and they're going to have localized symptoms depending on the location of the tumor. Diagnostic tests will include CT scan, always first. They may have MRI. They may need to do a needle biopsy of the tumor to determine treatment options in the future. They may need a stereotactic biopsy, which uses a special frame and computer to localize the tumor. And then if there is any fear that the blood vessels are involved, they may have a cerebral angiogram or arteriogram. Medical management of brain tumors has a couple of objectives. We want to decrease the size of the tumor. We want to improve the patient's quality of life and improve their survival time. Medications that may be used are some of the same ones we talked about with head injury. They may have steroids, Decadron, to decrease their cerebral edema and help their headache. They may have anticonvulsants to prevent or control seizures if they're having seizures. They may have anticoagulants, and these would be used to prevent deep vein thrombosis if they are inactive. And they may need antidepressants to improve their cognition and help them to cope during their treatment. Chemotherapy may be used alone or with radiation. This chemotherapy would be specific to the cell type that was determined during the biopsy. But this is the time when you need to remember the blood-brain barrier. We may have to give very large doses of some of these chemo drugs to circumvent the blood-brain barrier. Radiation therapy may also be used, and the goal here would be to decrease the size of the tumor. Either in preparation for surgery or to relieve the patient's symptoms. Usually radiation therapy is a 6-week course of therapy every day. Stereotactic radiosurgery uses radiation to deliver very precise amounts of radiation to a very specific location in the brain. It requires a rigid head frame that is applied during the procedure. This head frame is uncomfortable, but it immobilizes the patient and provides a reference for the patient's tumor, so it's very precise. If surgery is the first option or an option after the tumor has shrunk, craniotomy is the procedure that would be used. This is an incision into the cranium performed to remove clots after subdurals and brain injuries, to remove tumors, to relieve increased intracranial pressure, and sometimes to control hemorrhage. So craniotomy is an incision into the skull or cranium. There are 3 approaches that we can use, or that the doctor can use. The first one you see is a supratentorial, and that is a frontal approach. The second is an infratentorial, which is a posterior approach. And then a transsphenoidal approach is through the mouth and nasal cavity, and this might be done for a pituitary tumor. Before a craniotomy, this is how we would get the patient ready, or what we would expect them to have done. They're all going to get a CT scan to show the lesion, to show the edema. They may have an MRI. They may have an angiogram if it's going to involve vasculature, and they may have Doppler studies. Some of the medications that will reduce the risk of post-op seizures and control cerebral edema are going to be anticonvulsants, steroids, mannitol, other diuretics like Lasix, and perhaps antibiotics. These patients need to be off of their NSAIDs and off of any anticoagulants for 5 days to decrease the risk of bleeding. They're going to be NPO after midnight, or at least for 8 hours. They may still have a Foley catheter to post-op for a day or so to monitor their urine output and their fluid status. They usually are going to have a central IV line, such as a triple lumen catheter for fluids and monitoring. And now, thankfully, they are doing the clip and preps of the hair in the OR, because this is very traumatic for the patient and for the nurses who used to have to do that before we took them to surgery. But I think pretty much now they are doing all of this after they get the patient into surgery and somewhat sedated or anesthetized. After surgery, they almost always will at least spend a night in the ICU. We're going to monitor them for symptoms of increased ICP. Now, these are not patients who would have one of those ICP monitors, because it's going to be for a short term. So we would need to use indirect measures for assessing for increased ICP. We want to do frequent vital sign and neuro checks. The patients, especially the ones who have that frontal incision, are going to be very swollen and edematous and have black eyes after surgery. So we want to put cold compresses to their eyes, and this can be accomplished by just putting iced water into a water basin and dumping some 4x4s in there, and then squeezing out those 4x4s and applying them over the eyes. They will certainly be on a cardiac monitor. Positioning is very important. We want the head of their bed elevated, and we don't want their neck to be crooked or flexed. This is an important position for any neuro patient, Remember, they don't have good venous outflow, so we need to use gravity to drain those venous sinuses, and we want the blood vessels in the neck to be patent. So nothing drives a neurosurgeon crazy worse than coming in and finding his patient with their neck and head all slumped over to one side and not elevated, because it is very important for circulation post-op. We want to monitor that dressing over the head. They usually will have like a turban style dressing, and sometimes they will have a drain, such as a Jackson Pratt, sometimes a small hemovac. We want to be especially careful monitoring their electrolytes, especially their serum sodium. We're going to control their pain with opiates, hopefully even PO opiates shortly after surgery, like hydrocodone or oxycodone. They will continue to get their anticonvulsants, just trying to avoid seizures. And they may, or usually are, placed on some kind of stress ulcer prevention, such as the H2 antagonist, the PPIs, and they may receive decreasing doses of Decadron, which is a steroid, to help with the reduction of swelling postoperatively.